So we're assuming for the people, somebody who just joined on the video, that we have a PUI who's been identified in the emergency department, who's coming to labor and delivery, and maybe is in early labor.
So we're ruling out a triage. We're gonna go into one of the antepartums, preferably antepartum 2, which is a little bit further distance from the nurse's station and the actual triage. So antepartum 2, where a nurse, so one nurse will be assigned to that patient. Again, as assuming that she is a rule out, we will use full PPE at this point, so gown, gloves, goggles, and we are gonna provide the nurses, given that we have them, the N95s for, let's go ahead.
Do you have a rough count how many N95 masks you have allotted right now in total?
Right now, we probably have like approved, I would say, 4 boxes, so in each of the isolation rooms, and then we have hospital unapproved, about 100 in our office.
Boxes,
Your
how
office.
many?
Yes,
Okay.
they're not
How many
approved.
does a box have?
A box has, I think, 12.
So at this point, a patient taking care of a PUI, or a staff taking care of a PUI pregnant patient is in gown, gloves, goggles, and an N95. That obviously could change if we run out of N95s, but for the current time, in labor, in triage, in the OR, it's N95s, for sure in the OR and in the labor and delivery.
Okay.
How, in the ER, how does the screening process work, right? Because sometimes if this lady comes, usually the story, at least before this patient comes in, they're all uncomfortable riding in bed, and like the first thing they would do is like rush them up here to labor and delivery. Is somebody doing the screening, or?
They're still screening them, and we do an additional screen here when the ER calls. The MOA asks, is the patient symptomatic, do they have fever, and that is then communicated.
So what-
there's two-way communication.
So what should be happening if the patient has both OB issues and respiratory issues, the initial evaluation is supposed to be, the evaluation of the respiratory issues is supposed to be in the ED, and we get called to provide the OB evaluation in the ED. If the patient is pregnant and has respiratory issues and no OB issues, then she gets evaluated down there. But before anybody comes up, we get called so we know if they're PUI.
And
I think, we should treat two things here. I think we should treat the patient that is under investigation, the PUI. Also, someone that's already positive for CO, the COVID-19, but she's not terribly symptomatic, but she's coming with symptoms of labor, with signs of labor. So I think we should treat those patients the same.
So treatment and management at this point of a COVID positive and the PUI is the same.
same.
The only difference is that the PUI will get tested, and so her status and how we treat her newborn and so forth may change. So if somebody's admitted with a PUI, I have this posted in the labor and delivery room, but this is Ventura County Healthcare Agency inpatient and emergency room checklist for managing a PUI or COVID positive patient.
And so the physicians though as well, we do have a resource binder in both the nurses station that have all of the forms that have been being distributed throughout, the course of the last 2 weeks. We are updating, so anytime there's an update with like the checklist, for example, that is then replaced into the binder. So all the forms you need, logs, everything is in our resource binder that's located in the nurses station.
If you happen to be the attending or one of the residents here, this checklist changes about every day or two, so look at the one that's posted there, look on the website and see if there's a new one posted. There is an EMER COVID power plan in Cerner. If a pregnant patient is a PUI, then we do want to make sure you'll notify the house supervisor. We'll make sure ID is involved. We do want to make sure that the COVID test goes to public health for now, because that can turn around in a day. There's a rapid test that may be available soon that's like a 45-minute turnaround, but for now you have to make sure that the test, which presumably was done in the ED, but you may need to call down there and make sure that test goes to public health. So now we got him in a triage.
Go ahead.
Once we have it in the patient's room, then the nurse will basically do the whole triage
In the room.
In the room.
Yes.
call to the phone or just give us a report? Will that?
She'll have to probably give you a call and then the decision, that way we're not coming out and then having to re-gown and go back in.
Question in terms of logistics with
May I help you?
the patient coming up to the actual floor. Will
Push the
that
big button.
nurse who is going to receive the assignment be the one heading down to pick up the patient?
I think that's best, just so again, we're minimizing, and one thing we learned yesterday is you can be in PPE during transport, if it's the same patient, so if you wanna go down, be, in your PPE and then come up and continue your care into
Right.
the room from the ER. But she's gonna be clean, right, going down.
So just general principle is that, we'll manage people with the fewest possible providers, that we get away with. So residents probably will not be involved because the resident who's on the floor is gonna be running the floor. So let's say we decide now that she's in labor, and now we're gonna move to a labor room.
Well, hold on a second. Let's say that she's not in labor, that
Right.
we're gonna send her home. So that's a different thing.
Home, or she stays in the antepartum, is
Yes,
the other.
before we get into the delivery. So someone goes in, one of us goes and examines the patient, and she's really not in labor. You also need to do an ultrasound, for whatever reason, to check the fluid, blah, blah, blah. The ultrasound needs to be really sterilized when it gets out really clean. And then if we need to send her home, what are the precautions that we give to the patient? That's another thing that we need to,
So there are PUI, or there are COVID disposition papers in CERNA, in patient education. I think if she's a PUI, then we're gonna test her and hopefully get her results back before she goes home. I guess if, honestly, I'm not sure what we do if she's just a PUI, rule out labor, rules out, and then we gotta figure out what to do with her.
Well,
I mean,
if she goes home under
Yeah,
those
she
instructions,
goes home
just
and
like
gets
someone got their
quarantined,
nose
just
swabbed,
like
Correct.
she goes home
urgent
self-quarantined.
care.
Correct.
So she doesn't have to sit here
Yeah,
waiting
no.
for the result of the test.
No, she does not. She can just go
And I
home and then
believe
we'll give her a call.
The
As long
tests
as
are
there's any
batched
other
in public
criteria
health
for
at
that.
11 a.m. I've been told, so.
Right.
I
it's
think
like-
they're collecting every 2 hours, they said this morning.
Right, but so cutting from here, it has to get there in time for that batch, and you're very likely gonna miss it, you're gonna be waiting for another day.
We could send her home.
I guess just as I think about it, and people may have different opinions about this, I think, normally, we'd like to not admit somebody till they're 4 centimeters, so we have them go home, we have them come back and so forth. Probably if somebody's in early labor but booming out contractions and they're a PUI or a COVID, we're probably better off just keeping them, because they don't need much care at that point, but it's probably better than having them come in and go home and come in and go home, so.
If someone's clearly in labor and comfortable with staying,
Right.
what about the concept, the nurse is gonna be there to assess them, have the nurse check them, do you want the doctor to go in every time? I'm just thinking about how much.
Have the doctor go in every time,
Go in
what?
and see the patient and do it all, 'cause then
No,
you
I think
come out
the
and you're gonna use
nurse,
up
I
one
think
whole
the
set of
doctor
PPE.
only needs to be in the room if the doctor needs to be in the room.
Okay, right.
And I think the same, we haven't moved to the delivery room yet, but I think, we have great nurses who are awesome at managing labor, that once we move to a Dell room, the patient's gonna have one nurse, presumably, and one physician. But the physician, I think, as long as everything's going well, physician goes in when the patient's crowding to deliver the patient. I mean, nurses can manage the labor. So let's go, are we ready to
So
go into the Dell room?
are we clear with triage, antepartum?
So she will be triaged in an anteroom.
Anteroom, right, because we don't wanna risk exposure
Mhm.
here.
And the anterooms are they negative pressure?
They're
We don't
not.
have any
We don't
negative
have any
pressure
negative.
rooms.
But they are a quicker cycle, it's 12 cycles and it's fresh, it's regular air, so it's a different cycle.
So then the delivery rooms that we'll go to are room one
One
and
and
two, because they're the shortest direct shot to the operating room if we need it.
In a way, yeah, so we're not crossing through path of travel, the nurse station and the triage. So room
Wa-
one's
wanna
and
walk down
two.
there?
Sure, you guys wanna go there? And if by chance both ante rooms are taken, we'll utilize labor 1 and 2 as a triage or ante room.
So, the nurse, per most recent guidelines, who was with her in triage, could bring her in here, right?
Right.
That may not be the nurse who you assigned to be the COVID nurse. The nurse then who would take care, who was assigned to take care of the patient, would gown and glove out here before going into the room. The patient's support person, if it's husband or whoever, can be in the room for support, but also needs to be currently in PPE, gown, gloves, goggles, and 95.
And we need to stress to the support person that the mask needs to be on the entire time. It can't be that they're taking it off when you're not in there. It needs to remain on.
And if that person needs to go to the bathroom, they use the bathroom in here. They don't come in and
They
out.
have to stay in the room,
Yes.
They have
Right.
to stay in the, correct.
Right.
So do
Let
we
me say-
provide our own?
Let me say something else. When we transport the patient from there to here, okay, that patient needs to have a mask on.
Right, that's what
And
I'm
also, and apparently they're also supposed to have a cover sheet.
Right, so the patient,
So we don't
anytime
forget
they're
that.
transported, yeah, thanks. Anytime the patient's transported, they should be in a mask. They don't have to be in an N95. They can be in a surgical mask. And they should have a sterile sheet put over them before they're transported.
And we're using sterile sheets because there's more of an abundance of this half sheets, so we'll have those available for transport.
So when we go down to pick up the patient, we should take that with us in preparation to bring them up.
To bring them up.
Yeah, actually, yeah, it's perfect, right, hadn't thought of that.
Thanks, yeah.
So then the nurse who's taking care of the patient in the room, Christina, what kind of gown?
So nurse taking, at this time, we have the yellow gowns. So yellow gowns, gloves, goggles, N95, and if you want to cover your hair as well with the boffets.
For the delivery itself, regular gown.
Regular gown for the physician.
Surgical gown for the physician, okay? And as we said, the physician, the attending who's here, along with the backup to the attending and the satellite doc and the AFMC attending will decide who's gonna be the COVID doctor, right? And that person really, and the resident won't be involved in that delivery, just to limit personnel. That person, doesn't need to be in the room unless the nurse needs the person to be in the room to do an evaluation. So, as we said before, literally you could go in there when the patient is crowning and do the delivery. If somebody does have to go into the room, so if the physician has to go into the room to do something, he or she, when he or she comes out, takes off gown and gloves. You can take your gloves off with your gown. Those go in a trash can in the room. Then you come outside and take off, which comes off first?
So you're gonna, and gel your hands, so hand hygiene between every exchange of your PPE. So prior to removing your gown, you're gonna gel your hands, remove your gown and gloves, do your hand hygiene. You're gonna come out and you're going to do your goggles first.
And
do
then you wash your hands?
Hand hygiene, and then you're gonna do your mask. And you should turn your back away from the room.
And then outside the room, we should have a place to put goggles, because they can be reused. At this point, we'll be throwing the mask away, although there are all sorts of machinations going on about figuring out how we could potentially reuse masks. But, so, gown and gloves come off in the room, come outside, wash your hands, take off your goggles. I can never remember
Wash
that. Take
hands.
off your goggles, G comes before M. Wash your hands, take off your mask.
And you can see, you have your inlet here. I mean, imagine that being your ante room. So use that space as your removal of your goggles and mask.
A couple more things. For these patients, we're gonna really recommend for them to really have epidurals and labor. Really, because if we end up doing a crush section, it's much easier to do, hopefully it's easier just to do it with the epidural, and that way you don't have to intubate the patient and expose everybody to all the, aerosolized droplets. The other thing is, we are gonna also recommend to do all the deliveries on stirrups. because that will really decrease, hopefully the blood loss, the tears, and everything else that comes in. So no bed deliveries,
You don't want to be
so,
sitting in a puddle.
Yeah,
right?
yeah, so.
So encourage nurses, docs, encourage your patients to get an early epidural, then we'll ask anesthesiologists to, keep them moderately dosed up. So the whole goal here is to avoid a situation where we get aerosolized coronavirus, which is what happens if the anesthesiologists have to intubate them. So it's a risk for them, it's a risk for all of us, really a risk for anesthesia if they have to intubate. So early epidurals, and then the other point about labor management is that these aren't the patients who we're gonna, we're not gonna do a 4-hour second stage. We're not gonna watch
For 3 days.
nasty variables for an hour, hoping we can get them delivered vaginally. Because we're okay with doing that. We're comfortable doing that when we know we can run back there and crash them. But we don't want to have to be in a position of doing uncontrolled emergency C-sections in the COVID or PUI patients unless unless there's no other option.
If we have meconium, or if we have to have the NICU come in, what we're gonna do is we're gonna give them a call, obviously ahead of time, and have the carts also over here for them to really gown and glove and everything else so they can go into the room. And there's not gonna be any, when we deliver the baby, it's not gonna go to the mom's chest. That's not what we're doing. It's gonna go straight to the people that are either the nurse that is receiving the baby to put it on the bassinet, or the NICU personnel that is going to take care of the baby, so we can, eliminate the exposure. Yeah.
So the baby, once the baby is born, the baby is a PUI, right? So let's assume that, and some of this stuff we're working out, but let's assume that the baby, let's assume that everything went well, baby delivered. So after delivery, current recommendation is to separate the mom and the baby if we have enough room. So mom and baby in adjoining rooms. Per the webinar that we were just on, the support person who was in the room for labor and delivery should actually not be the caregiver for the baby, who at this point is presumed to be uninfected because that person has now been exposed. So even though that person was in PPE during the case, should not be the caregiver for the baby. It may come to pass that we don't have enough rooms it's likely that we're not gonna have enough rooms to have the mom and the baby in separate rooms, in which case we would put them in the same room, keep the mom and the baby separated by 6 feet, maybe some physical barrier between them. The NICU is checking on how many enclosed incubators they have so that the baby could be, enclosed.
Yes.
And then yeah.
So I have a question in terms of the delivery, with the Panda being 3 feet from the bed, would we move it? I mean, that's where we have our oxygen and our air.
I mean, maybe for initial resuscitation, because that, like you said, that's where we have it, and then we move away, maybe into the cubby,
Okay,
into alcove. That's about 6 feet, right?
I think so.
No, the thing that is not clear to me is, are we gonna have the patient on mask while she's pushing? I mean, group punishment. I mean, that's not gonna be able to.
I mean, is she gonna have a surgical mask on?
Mask when
Yes.
she's pushing?
That's the
She's gonna have a surgical
Mask
mask on
throughout.
the whole time.
Except in the event that we have to do oxygen.
Oxygen.
Yes.
You could actually do a nasal cannula under a mask. So that's an
Potentially.
option.
Do we have those?
We do. We could, yeah.
And
do
actually,
some in the OR.
I don't know, Nate, can you put a mask over it? Can you put a
You
O2
can't,
mask
it doesn't
over?
really give you much protection putting the mask over
Oh, but
the face
yeah.
mask. The face mask is basically having protection. But do you guys have a policy on flow of oxygen? The only reason I ask is there's some evidence over 6 liters that you're aerosolizing.
Oh, so I would say keep it under.
And then that number isn't solid. Some people are
I mean, we don't
saying
have
it's
that
less,
much
but-
evidence than putting a mask on
Oxygen
somebody
doesn't
with
actually
B
do a
cells
heck
is
of a lot,
helpful
like a
anyway.
lot of things we do,
Yeah.
so that you
Right.
can make it 5. you're really going from 5 to 8, you're not oxygenating the baby. The whole theme is that you're gonna oxygenate the baby, and that's extremely inefficient. I don't care how much you crank it up. So for a safety thing, you might wanna consider, if 6 is the number, go to 4, go to 5, because you're not getting more back from
Oh, yeah, that's a great.
Well, a lot of it's for mom, right? If mom is, we're just trying to oxygenate mom, is that correct?
Yes,
Also,
yeah.
not necessarily like a
Well,
resuscitation.
that's true,
for-
although if we're truly in a spot where the mom is desatting, then we got a whole different,
It's a
Yeah.
whole different
then we
story.
got a whole different scenario, and they may not even still be able to be here.
Right.
Yeah, they may
Yeah.
do the vaccine.
Fred, so baby's delivered, mom's not gonna be the caregiver, the support person not gonna be the caregiver.
Correct.
Who's gonna take care of the baby?
Well, either, if there's a healthy family member at home, they could become the caregiver
Oh, okay.
for the baby, or the nurse, or a nurse.
And that's where our ratios change. I mean, I know there's a lot to consider, but we have said that they're gonna be 1-to-1, so that's where we just have to
So
try to
that's-
get, some more staff in.
But the same nurse that's caring for the mother can't care for the
Correct.
baby, so it's
No.
still gonna be 2 nurses.
So at this point, no more breastfeeding?
So, great question. So, current, most conservative recommendation is that the mom either doesn't breastfeed, or the mom, it's encouraged that the mom pump the breasts. She has a mask on, she washes her hands, she pumps breasts to keep, even if she's not gonna give the milk to the baby, to keep her milk supply in, because she's not gonna be COVID positive forever, right? To keep her milk supply established, and then we can have a nurse or caregiver feed the pumped breast milk to the baby. Okay? The decision about whether to let the mom breastfeed or not is gonna be a decision that's made with the mom and the family. If the mom insists on breastfeeding, then the nurse will have to help with, but she'll have to wash her hands well ahead. She will have a mask on because she's COVID positive or a PUI, and then she breastfeeds the baby. There's also discussion, with the family about whether the support person who is in labor and delivery is able to help with the baby and be the caregiver for the baby too. I mean, we can't, these aren't like edicts, we have to involve the family in the discussions.
The other thing that we forgot is that when the patient comes in and she's already in labor, we need to notify the NICU that she's here. We also notify anesthesia ahead of time that we have a patient with COVID-19.
Right.
So, because they're gonna be called at one point or another, so we have to really.
So we
let
need
them
to-
know.
I would recommend if you have any COVID positive, just call the NICU, please, so that in
Right.
case
Yes.
something comes up.
Yeah.
So we need to call, if we have COVID or PUI, we need to call NICU, we need to call nursing supervisor, and we should let anesthesia know.
So similar to a TOLAC.
Pardon me?
almost. Similar to a TOLAC.
Or a high risk
Correct.
delivery, yeah.
Right, yeah.
Just like a high risk.
Okay, there was something else I was thinking about.
Well, hopefully.
Shouldn't have rubbed my nose.
I know we.
Take that, edit
There's
that.
job.
Wait, it's not washing my hands. It's so itchy.
Well, hopefully everything goes well, but sometimes things don't well even on vaginal delivery, so we may end up having a postpartum hemorrhage or, big lacerations, and we're gonna rethink about.
So
those
for
things. So,
the nursing staff, so a couple of things, assure that we have a resource nurse available that is aware, when everything's going on, in the event that we have a hemorrhage or whatnot, if we need a runner, who's gonna, be the runner to
Toss us meds.
bring the supplies in, right, and I forgot, I lost my train of thought, sorry, we'll keep going.
Having a,
Okay.
yeah.
So, now we decide we need to do a C-section. Okay. So, obviously, yes.
Prior to the C-section,
Uh-huh.
so say in a scenario where she's having recurrent variables, traumed, we at that point will likely need a physician to insert an IUPC if,
Yes.
is that still an option, like
Yes,
amnio
for sure.
Yes,
inclusion?
oh, yeah.
For sure.
If the baby has any issues, we're gonna come into the room, we're just not gonna be managing everything through here, no, we're gonna come into the room.
And I don't think, it's not gonna be crazy if the attending at that point says, let's just
Going to section.
we're going to section.
Okay.
So we're not gonna continue to follow some things that we might have otherwise.
So let's start with a patient that doesn't need to have a stat C-section, Okay, let's say the patient, she has failed to progress, failed to descend, whatever, or for fetal indications whether in a crashes section, we're gonna let the anesthesia, be cold, and also once they come here, they're gonna be basically setting up everything in the operating room, and we're gonna wait for them to give us a call so that we can transport the patient from the room, and the same providers, the provider that is there and the nurse that is there, we're gonna take the patient to the operating room.
Another sterile gown over?
Over the patient.
Another sterile
Just over
gown.
the patient, yes.
So the point is that there's no stopping between here and the operating room. They don't stop in the hall, they don't, stop in the room there, so we need to know that the anesthesiologist is there, that the that the setup is ready, that basically they're ready to take the patient into the room. And the patient doesn't come out of here and go into there until we get word from the OR that they're ready to receive the patient.
So the attendant that is going to be the C-section, and he's gonna be actually in the OR with all the N95 and everything else, waiting for the patient, and and the nurse also in the operating room, so we can take the patient from the outside and just bring the patient inside, and then we can assess again right there whether we really need to do a C-section or not, or whether she needs to be put to sleep, or we can just proceed with the epidural or with the spinal. So we can reassess the patient right there.
And you'll have how many nurses will be in there at that time?
Ideally 2.
Okay.
That's the plan.
Okay, all right.
For transport.
Felicia or the scrub tech will set up a dressing tray basically with gowns and gloves on it, so the surgeons won't. Normally we scrub and we put our gown, mask on, whatever, and then we walk in, or we put our mask and eye protection on and walk into the room in gown. It won't happen that way. So she'll set up the table. It'll be pushed just outside of the OR, and we'll scrub, and then we'll gown and glove ourselves outside the room and go into the room to do the C-section.
If for any reason the anesthesiologist needs to put the patient to sleep, we're gonna wait, and we're gonna be waiting outside until we get the go by the
Clear.
anesthesia to come into the room, so we don't get again exposed by that.
So the nurse in full PPE and the anesthesiologist would be there. Intubate the patient, give whoever else needs to be in the room the all clear, and then we'll go in.
Correct.
So do you want your setup on the outside, when you make the decision you're gonna go for a section, you want your stuff open first on the outside, and then I can go in and start to open and set up?
You'll have to
Is
set
that-
up, but if it's a general, then you would leave again while we intubate. So the only people in the
Correct.
room during intubation would be the circulating nurse and the anesthesiologist.
Okay.
That's it. And the reason being, when you intubate, you're aerosolizing the droplets. So you want to have the airway secured and attached to a HEPA filter in the anesthesia circuit. And then when that is done, then everyone else can come in the room.
But I'm saying the
So
little
then you can
table
come
on the
in.
outside where you're gonna gown and glove, open that first, leave it to the side for you, then I can go in and open and set up my stuff?
That would work, you put a thing over, you just put a
I think
drape
either
over,
way,
it's like
I
a
think,
drape over.
yeah, I think
Okay.
you set it up, put a sterile drape over it,
Okay.
and sit there waiting for us.
So
Okay.
that's only if the patient's already in the room though, right? Because if the patient's not in the room, you could pretty much do what we do now. You guys could go in while we're taking the patient, put
No,
all your
no,
sterile.
No, because
No?
you can't walk in with short sleeves and everything when the patient's in there.
No, I mean, before the patient's even in the room. So let's say we're going to section, the doctors go,
Get all prepared.
get all ready, get prepped, go inside, get completely prepped, and so you're already prepped. And
But
so
in
then we
the-
don't even have to do the table thing.
But in the event that the epidural can't be used or a spinal doesn't
Yeah,
work,
so if she needs to be intubated, I see that's
then they'd
different.
have to walk back out
But
already
you see what I'm
sterile.
saying?
Sure, but
Because,
the doctors being in there that long before the patient's in there, before they're put on the table, it's a really long time. I don't think that's practical.
oh, okay.
I just don't think, to have two doctors standing in there trying not to contaminate themselves, which might be a really, really long time.
It's a good question.
It's a, yeah.
Okay, no, I was just,
Yeah,
okay.
yeah. Is that how they're doing it in the main OR? They're gonna gown outside the sterile court and the sterile
Correct,
corridor?
yeah, so they'll wait till everything's done, and then they're gonna gown outside.
Okay.
Yeah.
And then, you know, NICU, if they, you know, if they don't need to be there, they're not gonna be there. If they need to be there, they'll be set up, you know, outside the room so they can come in.
Which we may need to have we may need another table for the NICU, because otherwise, you know, or just more
Well,
gowns.
We'll just put more gowns,
More
we're just
gowns.
gonna have a table.
Yeah.
So one question I have is, with an epidural, you know, sometimes they don't always give adequate anesthesia, and then once you've dosed it up, or, you know, usually then it's going to sleep, because you can't do a spinal at that point, because
Right.
you don't know the level. So then are we gonna excuse everybody and start
think we
over, or?
Well, we
If
can
you
do
had
that.
to if you had to intubate,
I
we can do that.
You know,
Yeah.
everyone can step out of the room, even though I've started
Like
the
an X-ray,
operation,
yeah.
right?
Right.
Careful.
Right.
Stand outside the room, you intubate, I go
Intubate.
back in.
Yeah.
Okay.
I mean, everyone,
I think that's
we
good.
can do that.
Yeah,
Yeah.
I think that's good.
Right, don't you? I mean, that's the best,
That
I mean,
makes sense.
it's not ideal, but it's the best
Yeah,
way.
I think that's good.
I mean, I think for practical purposes, this, you just have to accept that this is a less sterile approach than what we do now, less ideal approach, okay? What we do even now isn't sterile, but I think we just have to, everything about what we're doing is a little different.
then when we leave the OR, the patient is not gonna go to the PACU, right? So we'll need to make sure now, if she has a general,
Right, that's a different story.
that's different, then we gotta figure it out. But if she's just got an epidural, then she'll go to her
Original.
postpartum room or the original room?
So we're gonna start in the original room,
Okay,
that we
okay.
don't, yeah, it'll be easier. And
Okay.
Dr. Weber, if she had a general, would we be able to at least do the first couple stages of recovery in the OR?
It'd be in the
So,
OR, right?
so the way
Recovery.
we're doing it
Yeah.
downstairs
Uh-huh.
is the anesthesiologist stays with the patient
Okay,
in the OR until the patient's recovered.
got it,
Okay.
got it.
So
I
we
mean,
can
and
always
that's
do
gonna
that.
be, you know, who knows what's gonna happen if we have those kind of resources, if that anesthesiologist has to go off and go somewhere else. So I'm sure for the interim, we can stay the entire time until they're recovered and then go back to the room. But there needs to be a little understanding, you know, as we get busier. You know,
Potentially
we'll stay
that's
for a
not-
while, and then hopefully you guys can take over once they're stable. But but like you said, recovery, you know, is in the same place, so you're minimizing where they are. So they stay in the OR, recover them in the OR, and
Just
then
until they're awake and, you know, more alert and
Yeah.
through the second phase.
There's something else that there was a little oversight. When we're doing a C-section over here, we also have to call the OR, that they need to have another room open, just in
Right.
case we end up needing to crash another patient, then we need to take the patient downstairs to the OR. So they're aware that we're doing a C-section here with a COVID patient, but we need to have another OR room available. for
And I would
patients
think,
C-section.
Nate, or maybe if you could weigh on this, because Jen asked it on our phone conference last night, if we have, I think there's utility in being able to do a COVID C-section up here, because it minimizes transport. So if we had a COVID patient in labor, our thought was it might make the most sense that if we had and otherwise, if we had somebody else to section, that we took them downstairs.
yeah, I agree. I mean, with the new information that there's 20 cycles of air every hour, each OR is essentially ready to go after 24 minutes.
Well, it's ready to go in an hour, because the 24 minutes
Is once it's
that's
clean.
that's when the cleaning people can go.
Well, I hope they
And then
clean
it
faster
takes
than.
them. But it's
But
around.
no, yeah. No, I agree. I mean, and I think that's wise. You have a room ready, and making sure there's a room ready downstairs. At least they know and it's available. But hopefully we can wait. But if we can't, we can't. Obviously.
Are TOLACs still being allowed at this, like during all of this?
Yeah, we talked about that. I think we'll do that on a case-by-case basis, you know, I think we won't. So, there are a couple issues there. One is, you know, just doing the TOLAC itself. And, you know, sometimes that's quicker and easier and fewer resources. You know, someone comes in good labor as a TOLAC and they deliver and everything's fine. I think the guidance for managing the TOLAC patients will be, will probably be less likely to push it. And then the other thing that Nate brought up is, if you guys probably know, there's some anesthesiologists at CMH who are tested positive. So if we get into staffing issues, whether it's with anesthesia or OBs or nurses or whatever, then we know that when we have a TOLAC here active, that requires an extra OB, requires an extra anesthesiologist. So I could imagine getting to the spot where we just don't have, we either don't have extra people or everybody's been working nonstop and we have to adjust. So I think that's on the table. Any other anesthesia stuff you can think of, Nate, that we missed or?
That's about it, yeah.
So NICU won't be required to be in the OR. I mean, if we go to section, it's likely gonna be for potentially the fetal distress. We're not gonna sit on it, we're gonna go straight to section, hopefully try to avoid it being emergent. But wouldn't we probably still need NICU at least?
Oh yeah, that's not gonna change the
Same-
management,
same
if you have a patient that has prolonged fetal bradycardia or corprolapse and there is really, heart tones are really down, you're gonna have the NICU available there, that's not gonna change.
So they just wouldn't be in the OR, is what?
Well, if it was
No,
really
they'll
bad,
be-
if it
they'll
was
be in
really
the
bad,
OR.
they'd
Okay.
be
Yeah,
in
they'll be in the OR.
But if it's for variables or something, then I think they wouldn't have to be there, they could just
They
be ready
could just be
to come
ready.
in.
Okay,
yeah.
okay.
And then just depending how the kid comes out, you can then call them in or not.
I have a question back to a vag delivery. So if there's no skin to skin, baby's gonna go onto a towel on top of the abdomen?
Baby's gonna
No,
go into
to the
the
warmer.
How is a
To the
physician gonna
warmer.
clamp and cut?
straight to the warmer.
But how is a physician gonna clamp and, how does that look?
You hold the baby,
Oh,
you clamp-
physician.
we used to do it that way.
We used to do it that
Okay.
way, one hand delivery and blah, blah, blah,
I've
and
never
here's the
seen that.
baby.
Okay. So you're gonna hold the baby.
We dropped some babies.
That's what
That's why you're done by the neck, they don't fall.
By the feet,
I can just
the
sit out
foot.
there, don't do that.
Do you want it to fall or do you want it to have COVID?
Neither, I don't wanna be there.
Don't worry, we know how to handle those.
No. CT.
Spin the baby around, you put
Spin the baby, grab the
How does that
baby,
look?
suction the
How does
baby.
that look?
clamp it.
Just like when they have thick neck or something or floppy and you just clamp and cut
Onto a towel.
onto the warmer.
You
To
just
the
hold the
warmer.
baby, the delivering doc just holds the baby in
I've never seen
the
that.
arms. You grab a clamp,
Okay.
grab a clamp, okay.
Okay,
Yeah,
I've never seen that,
exactly.
okay, all right.
Wow, I never thought about that, but yeah.
Something like a ACN, at what point should I go into the room for a vaginal delivery?
You will be the second nurse. We wanna have 2 nurses available, so right before delivery, you'll gown up and be available for resource to then manage the baby. Cause we ideally want 2 nurses in that room. And we don't wanna have to utilize the charge nurse, the nurse, and then a TCN. So you'll act as the second nurse.
On the medical staff website too, there's a whole list of COVID resources on the medical staff website. So if you go to VCMC Med Staff, that'll take you to the site. Whole list of COVID resources, and somewhere kind of toward the bottom there it says, I think, N95 instructions or something. There's actually a good video from UCSF that shows somebody putting on and taking off PPE. And I mean, it's confusing to me, so if it is to you, it's worth watching that video a couple times, because it tells you what to put on in what order and what to take off in what order. Goggles before mask. Yeah.
Shoe covers too?
Shoe
For the
covers?
nurse, that's,
I mean, you can. I mean, I think there's not a huge. I think there's a supply of shoe covers.
Yeah.
But again, just be cognizant that you're not coming in and out with
Right.
them on.
Any other questions people can think of, or, well, I think we'll probably try to do this
Walking through it every morning.
once a shift, or
Yeah.
we should do it for the night nurses too.
Mm-hmm. We do it at a change of shift, so they're
Perfect,
both are
perfect,
there.
Perfect.
Mhm.
And then if you go away from here and you go, oh, I just thought of something, which is what happens to me when I'm usually laying in bed at night, then just text it out and we'll try to figure out what we would do.
Just since I'm not familiar with the process, so once the baby is born, right? So into Opanda, the transitional nurse will transition the baby, right? The other nurse will be on working with mom. So then from that point, do they get moved into postpartum?
No, so ideally, the nursery nurse will do all, again, so you're not coming in and out, we'll do the entire recovery in the room. We can move her over, there's an alcove in each room and very far away. These babies, we're not gonna wait for. Right, you can pull the curtain, we're not gonna wait for 8, we're gonna bathe the babies, you're gonna do everything, so they're clean, and then the transfer to postpartum.
And so at this point,
At the last step.
So at this point, your hope would be put mom in one room and baby in the other room, side to side.
Ideally.
And then kind of the Stanford guidance was to test the baby at 24 hours. So you would hopefully know if the baby was negative. And then Christina, well, this is kind of a separate issue, but she's set up something with, or been talking to public health nurses, so especially if we get in a bed crunch and we just need to turn people over, we'll be looking at early discharges rather than 48-hour discharges, 24-hour discharges with, this is for all patients, like I'm not talking about COVID patients now, but 24-hour discharge and then a public health nurse making a visit to the mom to do she check to see how the mom's doing, of course, but do weigh the baby and do a color check. And I don't know if they can do a transcutaneous filling.
We talked about loaning one out during this time.
So that may be something that comes if we need to get people out quicker.
And we're gonna keep a log on the physician, the nurses,
That actually,
super
important.
Yeah, and everybody that was involved in that case, so we can really do some follow-up.
Can we do like a whiteboard outside?
I mean, we could.
Or
So
paper,
But it's a pre-designed form, right?
Right. Yeah, so there's 3 forms, when we've been talking through it, there's 3 forms that need to go on the door of a COVID patient. It's the PPE signage, there's a stop sign that you guys have seen that says stop and only, people that need to be in there should go in there. And then the third one is the log of who is coming in and out, which also you put the time the patient is out of the room, so you notify EVS what time they can then go into the room to begin cleaning.
And
so
that says what type of PPE you have on, right?
Correct.
So that they know how to treat you if you
were exposed.
Yeah.
And then if you were the nurse treating the COVID patients, you would self-monitor for the 14 days. There is, again, in the binder, there's that log. You would, again, tell what PPE you were wearing, and you would monitor yourself for the 14 days. Those forms are in the binder. Also, they're on the medical, the website, right? The medical staff website. So there's 2 locations that you can locate them.
On a kind of similar thing with witnessing high-risk medications, could we have that resource nurse kind of just be here when donning and doffing? It's just kind of an extra set of eyes to make sure everything comes on appropriately and off appropriately. Just as before people go in the room.
We'll talk with
Physicians
that.
as well.
We'll talk
A
about that.
dofficer.
offline. Yeah.
That's what they call them.
Doc.
No, really.
Because the other thing
A
is
dofficer.
Dofficer. I mean, we also want to just maintain, distance, because you don't want somebody doffing when there's a clean person right in front.
Right.
So we just have to be aware of that as well.
So I guess the other thing to ask Christina is where are all the gowns? How do we? I mean, I know, but where are all the gowns? Where are all the masks? Where are all the goggles? And how do we get N95s?
Okay, so all our PPE closets have a very minimal supply of yellow gowns, the blue gowns for delivery, shoe covers, buffets, regular surgical masks. N95s are being kept locked, so you would notify nursing supervisor. If I'm here during the day, I have some in my office. So that, that's where you can find it. We do have extra in the med room, so there's extra gowns. There's goggles in there. There's, what else is in there?
But no N95s.
No N95s.
So with the same scenario of the ED calling us and saying there's a laboring patient, looks pretty active, she needs to head up there. And she's positive or symptomatic, a PUI. How quickly can we get an N95 before we head down there?
I think you could also communicate with the ER. I believe they have a larger supply of N95s. I believe Dr. Flossie is gonna put out this afternoon where the guidance has changed and a surgical mask is sufficient even with the PUI or COVID. Is that right, Enriqueta? So again, you know, if we're in there long term, I would probably wear.
That would be for transport, not for
right.
management of labor or in the OR.
Or in the OR. So you can wear just a normal surgical mask.
Thank you very much.
Anything else? All right, great, guys. Thank you very much.
Thank you.